Very much. It's a great privilege for me to join you today. This has been a great learning experience for me, and I hope I can share a few things from the healthcare provider world that will contribute to your understanding of where we are in healthcare. I've ambitiously titled this The Future of Healthcare. Let me just correct any misperceptions. I don't intend to predict what's going to happen in healthcare, but what I have to say, I firmly believe contains some truths that if we ignore, we will not be able to get to the kind of health care we as individuals and we as a society need as Americans. I think your topic, as has been said earlier today, you were extremely prescient in picking two topics. Little did you know when you picked those months ago how much more impactful they would be for all of us. But healthcare, I think, concerns all of us and has for a long time. Despite the things that we've talked about and will talk about, most Americans are pretty happy with the care they receive from their doctor in the hospital, but they're kind of vaguely aware that something's not quite right, it doesn't fit together. Well, let me tell you, after 40 years of being a physician and 20 years of being a healthcare leader in a large health system, I don't have any vague awareness that there's something wrong. I have total certainty that something's big wrong, and we can't fix it incrementally in healthcare. And we can't really look to government to fix it. It has to start with us. And I'm talking about us as providers of healthcare and those of us who finance healthcare. And I'd like to share some things that we've learned over time. So first, is healthcare's future primarily dependent on politics? Clearly it depends on what happens in the White House and in the Congress. But is it primarily dependent on the politics and who's in charge? It isn't, because the changes that are required are much more fundamental and core to the processes of delivering care and how we finance it and how we align incentives. And I'd like to go through some facts for you to consider in this. First, it's already been really well addressed by Leonard, is that costs are unsustainable. I'm a little reluctant to show this slide in an audience that contains so many world-class economists, but for a dumb doctor like me, I look at usdebtclock.org, that if any of you have looked at that live online, these numbers are all changing, and they're going generally in the bad direction. And it's been really useful as I've had physicians and pharmaceutical representatives and device manufacturers say, I got this new thing we got to do, and people are just going to have to come up with the money. I say, why don't you go look at this and look at the unfunded liabilities and look at down here at the bottom line, hard for you to see, but unfunded liabilities from Medicaid are striking. And said more simply, and Leonard covered this point really well, but Shannon Brownlee, who is the author of the New York Times bestseller, Overtreated, said it simply: when you think of the budget deficit, think of health care. When you think of unemployment because of unaffordability for employers, think of health care. And really to your point, Larry, when our children's future depend on whether or not we can solve the healthcare cost problem in this country. I couldn't agree more with that. Second fact, and Leonard also mentioned this, is that healthcare outcomes are suboptimal. The United States excels in what we call rescue care, some people call intensive care, or some people call expensive care. If you're in a severe crash on the 101 or on I-5, your chances of surviving in the United States approach 2 times what they are in Western Europe in a similar accident. If you had advanced cancer, advanced cardiac disease, if your granddaughter is in the newborn intensive care unit, those are the places we exceed. But we do a dismal job at population health management, preventing illness through evidence-based best approaches to screening and chronic disease management, like chronic management of chronic diabetes, of asthma, of hypertension. We don't do a good job. And the result shown on this chart, somewhat dated, is that we have far more avoidable deaths that could have been prevented by effective treatment in the United States than our first world counterparts. And in fact, the United States lags behind many countries that are not so economically blessed. So just, I think those 2 facts alone suggest that there's need for fundamental overhaul of the way we take care of our people in America. And I'd like to just share with you 4 other facts that we've learned at Intermountain Healthcare. And I moved from saying 4 other principles or anything, because I think we've understood this long enough now at Intermountain Healthcare that I'll tell you that each one of these is true. And if we redesign the health system without taking these things into consideration, we've missed the boat and we're not going to get where we need. First, data drives improvement. We've been blessed at Intermountain Healthcare, which is a large integrated delivery system based in Salt Lake City, for years due to the visionary work of people in the 1960s and 70s, an excellent data system that allows us to track costs and clinical outcomes. And what we found at Intermountain Healthcare is every time we objectively measure how we're doing, we find that we're not as good as we thought we were. And that's sobering. And it, it's that you have to kind of confront the brutal facts to get better. The first place we use this in any clinically significant way turned out to be something that I was involved with back in 1988. So this is me in 1988. You can see it's a long time ago because of my fashionable eyewear and the lack of definition of my biceps, which is a reflection on the poor optics of cameras of the day. But every Tuesday morning we had at 6:30 in the morning, we got together, the 7 people in our division of urology, and had x-ray conference with our 2 residents on the service, and we'd look at cases that are coming up and talk about that. And so one day we were sitting there getting ready to start, and one of the finance people from Intermountain Healthcare that we didn't know very well, and another guy who was a physician in critical care medicine, and a rabbi came into the conference. Okay, no rabbi, but the other 2 came in, and they said, hey, we have some data that we've been wanting to show you. Can we show you this? And we kind of looked at each other and said, who are these people? We're polite, we say, sure. So they fire up the overhead projector and the transparencies, and they've been looking at our individual performance as surgeons on a very commonly done operation there in that time, a transurethral resection of the prostate, not for prostate cancer, but for benign enlargement of the prostate, which is blocking urinary flow, going with an endoscopic procedure and remove the obstruction. And they had tracked us all for about a year by individual physician on length of time in the operating room, how many grams of tissue resected, whether or not patients needed a transfusion, how long we were in the operating room, how long you stayed in the hospital, whether or not you used antibiotics, if so, what. And they had us all charted out, individual by doctor, 7 of us. So we're all looking at people I can remember being there. One of my friends leaned over, who did you say these people are, Charles? And what do they know about us? And how, can they collect data on our patients? They didn't tell us this. So they said, now we don't claim these data are perfect. If we need to collect better data that's more relevant to you, tell us what that is. So that started discussion, and you all remember Kubler-Ross, who the stages of death and dying. So we went through all that. It was shock, anger, denial, depression, and then finally acceptance as we started to say, maybe there really is a variance, and how do you do this in the operating room? And can you really take out the catheter on the first day and you can get the patient home in a day or 2? And what happened with no other pressure than just showing the data and having it before us is that everybody improved. Even the people who were better on some of the measures weren't good on all of them. And all of us together improved. Why? Because doctors want to do the right thing for their patients. And when they see the data, they'll work hard to figure out how they can improve. That was a really signal study for us back in 1988. It was what we based our efforts over really the next 30 years on, almost 30 years, on what we call clinical programs, where we use data managers, clinical experts, and tracking and setting goals and improvement in 10 different clinical areas. So let me show you a couple other examples from what we call our clinical programs, because we came to understand that quality and cost are inseparably linked. Not in the way that most of us think. Most of us think if you want better, you spend more. We found that something else was happening in healthcare, that if you follow evidence-based practices, do it consistently, eliminate unwarranted variation, you get better quality outcomes for our patients, better clinical outcomes, and lower overall costs for a community. Not necessarily lower costs for the hospital, not greater revenues for the hospital, but lower overall costs for the community. So we're a not-for-profit health system. The board said, do more of that. If we can deliver better care at lower cost for the community, we're about that. So we have these 10 clinical programs. Let me give you a few examples. One, this was an early one from back in 1999. It was known for a long time that if you're going to induce elective induction, elective labor, that you shouldn't do that before 39 weeks of pregnancy. Normal pregnancy is 40 weeks. And you know that if a woman gets close to that, if she's ready to deliver, or if there's a need, you can do various things to induce labor to start. Well, what was happening is there were a lot of social indications for inductions, like my mother is coming from Tennessee on this day, and it'd be best if we do it, and the doctor's going on vacation. So when we measured it, we were kind of surprised to find that nearly a third of inductions were done prior to 39 weeks. So we went out to our obstetrician and said, do you believe in this guideline of the American College of Obstetrics and Gynecology? He said, yeah. Well, why do you think a third of them don't meet the guideline? The uniform response was, well, after you've been in practice, you can tell, and 38 weeks is as good as 39, and 37 weeks is usually pretty good if you feel like they're ready. So we said, oh, really? Well, we went back to the data managers, and in 3 days, the data managers were able to accumulate what happened to these women and their babies when there was a premature induction. If you induced labor at 37 weeks, 1.12% of those babies ended up in a newborn ICU on a ventilator. At 38 weeks, it was 0.45%, less than half. And at the best time, 39 weeks, it was a 0.21%, a five-fold difference. Now you can see those are all low numbers, so even if you're a very busy obstetrician, you won't detect that in your own practice. But we showed those data to our obstetricians, and this is what happened. There was nothing else done except sharing the data and tracking the weeks when the patient came into the hospital for inductions. The result of that, we saved millions of dollars every year for the community by not having babies end up in the newborn ICU on the ventilator. And what we didn't really predict at that time is that we would develop in Utah the lowest cesarean section rate in the country, because some of those premature elective inductions, people get stalled labor and they have to have a C-section. Once you have one, then there's more likely you have to have another one. So we had better outcomes, and under the fee-for-service payment system, Intermountain was rewarded by making less money. Millions of dollars less, but we had a board. I can remember presenting these data. I was the chief operating officer at Intermountain at that time in 2000. I said, here's what happened, better outcomes, lower revenues. They said, go do that again. Go find some other areas. So we've continued that. Here's a more recent example. Our cardiologists got together and looked at the most common things that they did as cardiologists, interventions. Those included nuclear stress testing, putting a stent in an occluded artery, implantation of a pacemaker or an automatic defibrillator. And they went to the literature and their professional association and said, what are the most up-to-date indications for this? And we voluntarily, as a group of cardiologists working at Intermountain Healthcare, we want to have a checklist. So the patients who have that meet the guidelines. The outcomes of that is our clinical outcomes remained excellent, and we reduced the number of these procedures just in our Salt Lake Valley hospitals by $15 million alone. Again, lower revenues to the health system, better outcomes, or at least equivalent outcomes, not exposing patients to unnecessary risk, and savings to the community. This next one is moving to team-based care, and it's really what we call mental health integration at Intermountain. So picture this. You're a doctor, you say you're a surgeon like me, and it's the afternoon in clinic, and you're seeing a patient who's coming in for a routine post-operative visit from a surgery that went really well a month ago. So I go walking in there with a smile on my face. How are you doing? And the patient says, I don't know, not so great. And you're sort of surprised. Oh, really? Are you having pain? Yeah. Where? I don't know. All over. Are you eating okay? Not really. Well, are you nauseated? Yeah, maybe. Are you able to walk around, do your normal stuff? Not really. Now, okay, now here I am. You got 2 or 3 other patients who are waiting to see you, and you have this sinking feeling that you're being drawn into a black hole. So you do what typically doctors do in that situation. They say, well, we better check some things, and you order some x-rays, maybe even a scan, and some lab work, and maybe some test. to just be sure that there's nothing wrong, although there's nothing wrong in the exam. Really, it's kind of this, you have this magical thinking that maybe the patient will come back in a week and she won't still have these problems. Or magically again, that maybe then I'll have more time to talk to her and understand what's going on. And so that happens. All this stuff is done that doesn't add any value at all. Now, we implement it a different way in our Intermountain clinics, where we have an embedded behavioral health specialist who you can say, you seem kind of discouraged. Are you discouraged? And the patient probably say, yeah, I kind of am. Can I have Sally come in and ask you a few questions? I just want to understand this better. You go get her, she comes in a few minutes and comes back and says, Dr. Sorenson, your patient's depressed, and she's been depressed for a while as a result of all this thing, and I really think we ought to get her to see one of our behavioral health people or work with the primary care people on some medication. Tremendously improved satisfaction for physicians, for patients, and this is really interesting, lower overall costs to the community. We had emergency room visits go down, not emergency room visits for mental health, but for all other medical problems. Same with hospital admits. These aren't psychiatric admissions, these are medical admissions, avoidable visits and admissions, a little more primary care visits, a little more urgent care visits, but in our system, an urgent care visit in one of our Instacares is only about 10% more, and interestingly, decreased imaging studies. Obviously, people don't do imaging studies for behavioral illness usually. These are all better outcomes. So we had an investment for our own select health patients for whom we're accountable. This is the minority of the patients we care for at Intermountain, about 25 or 6%. But an investment of $22 per member per year for that behavioral health specialist decreased the overall medical expenses for that population by a whole lot. But we didn't just do this for our select health patients, we did it for everybody. So once again, better outcomes, fee-for-service pays us less. Fifth truth, better outcomes can't be achieved simply by improving provider performance. It doesn't work. So here's a story on this one. One of my good friends is a very experienced cardiologist. He had a new patient come see him about 2 years ago. And the patient came in and the chief complaint was, I'm worried I've got congestive heart failure. He'd been seeing a cardiologist in another health system in Salt Lake. And he told Dr. LePay, he said, I've been on these medications and I just don't feel well at all. I am fatigued all the time. I'm kind of nauseated. I'm worried that despite these medications that I'm on, I might be going into congestive heart failure. I have no exercise tolerance, I'm bad. So Dr. LePay says, well, what medications do they have you on? He said, well, I thought you might ask me that. So this is not a picture of the patient. But Dr. LePay the first thing in a physical exam is inspection. He noted the patient was about 5'8" and weighed like 300, data point. So he said, yeah, I thought you might ask for my medications. So while I was waiting out in your office, I wrote them down. And so here's the list of the medications. He's on a bunch of different medicines, some for cardiac, some for gout, some other things. And being the astute doctor that Dr. LePay is, he said, actually, I think I can see what the problem is here on this little piece of paper that you wrote down. Well, it's not on this, it's on the back, because he wrote this list on the back of his lunch receipt, with 5 cheeseburgers. If only he had had a diet Sprite, right? But this failure of us all to recognize our own behavioral choices and how that impacts on our health and our need for expensive health care is something that we got to fix. We've got to have incentives and aligned incentives for patients, not just financial incentives, because you know what? We've made other difficult social changes in this country. We got people from the 1980s who about 20% of us wore seat belts. Now it's way higher. It wasn't because they got an incentive to do that. It's because their little daughter said, Mommy, you're not wearing your seat belt. Don't you love me? And that's what's causing decreased rates of smoking. It's socially unacceptable. We got to have a greater social unacceptability of poor lifestyle choices in the United States. So that includes all of us. Well, I hope all these examples, you can easily see the common thread is that the current fee-for-service system under which most healthcare is paid in the United States actually penalizes health systems providers who provide better outcomes. It really does. And we need to move to a population-based system to provide that care. A couple of years ago, I guess it was about 3 years ago now, I woke up early one morning. I was kind of thinking about the day and thinking about what our responsibilities at Intermountain were, and I was thinking about my kids, all of whom live quite a ways away, and I thought, what do people really want for their families and for themselves? Our mission at Intermountain Healthcare was excellence in the provision of healthcare services for the people in the Intermountain West. I thought, is anybody lying in bed early in the morning saying, I hope this is the day I get really great care for a ruptured aortic aneurysm, or really efficient care for a stroke, or cancer surgery? I mean, if you got that, that's what you want. But what do we all want? You want health. You want health for your family, the people you love, and for yourself. So we went through a process, and it was harder than you might think, because people say, that's been our mission statement for 39 years. We don't change that. But the board was supportive, and we did change our mission statement to helping people live the healthiest lives possible. I wanted it from the very top of the organization to be our focus. We still need to be excellent when health care is needed and when rescue care is necessary. We need to be the very best there. But we need to prevent illness and prevent injury and prevent the effects of chronic illness from turning into an expensive event. And that's really been energizing for Intermountain Healthcare. It's not easy to make this transition to population-based health, but it's the right thing to do. And I'd encourage each of you, when you go back and talk to your doctor, talk to your health system there, your academic medical center, say, what about this journey to population-based health? Are you on it? And if not, why not? They'll say, well, that's probably where we need to go, but it's really hard right now, and there's all these other excuses. Really what that is, it's more magical thinking that somebody is going to come around and fix it, and the only people that are going to fix it, I think, is us. Thank you.